Hello, it's John Kanellopoulos from Athens, Greece, clinical professor of ophthalmology, NYU Medical School, New York City, New York. Really a pleasure to talk to you about a very interesting topic. This is what's now currently known as the Alcon Ingenuity 3D face-up intraoperative microscope. It's in addition to a surgical microscope that enables the surgeon to view on this 3D screen with special spectacles facing directly towards the screen in 3D surgical mode. And it's really accomplished in retina surgery. Here we'll show you us using the device. I want to thank Mark Mayer from the original company, Truevision, of enabling us to work with this. And we're seeing here our manual marker. We're marking at 17 degrees this ICL, a ToricIOL, central phakic IOL. It's our go-to lens for the last 10 years, certainly after the centriflow addition. We're marking 17 degrees. You can see the 6 o'clock mark seen upside down on surgeon's view that we place in the patients prior to the procedure on the slit lamp. We're marking the 17 degrees. We're going to use the Ingenuity system, or what was previously known as the Truevision system, in conjunction with a Cassini topographer to help validate the axis of the implanted ICL lens. I'm taking this opportunity to also show your updated technique with ICL. We're using methylcellulose here on the surface. Here's the plunger placed into the reusable injector. The plunger obviously is single use, and then in a BSS basin. And this is the injection cartridge filled with ProVisc, not methylcellulose, per the manufacturer's specs. This is the Vision Centriflow Toric IOL, and you can see the design and how it fits in the eye. It comes in this little glass vase, and I'm using a toothless, I want to underline that, toothless forceps to gently grasp the polymer lens. And you can always tell which side is up because it's concave. And I'm going to place the lens flush with one side of the cartridge and then use the toothless forceps to bend the lens and insert the other part of the front and back haptics within the cartridge. I know this deviates a little bit from what has been recommended by ICL and STAR, but this has been my go-to technique because I like the lens to unfold this way and not the reverse way, meaning not to open out towards the lens. And I'm going to advance the lens in the cartridge under direct visualization, so I'm avoiding the fact that the lens may twist as it's being advanced. So I have full control in the way I'm advancing the lens. Of course, if one is not gentle in manipulating the polymer lens, it's so thin and fragile you can tear it. So one has to be quite careful. And then we insert the cartridge that's flooded with ProVisc, lens in place, into the injector and locking it here like so. And I'm going to start advancing the lens, the ICL, within the cartridge tip in order to see if the ICL will take any torque. So I'm marking that exact point because I'm going to use the position of the current position of the lens once I inject it in the eye. And here I am with my standard 275 blade for clear cornea cataract surgery. Obviously for this injector, the 275 is not enough, so I'm going to enlarge it slightly to about 3.2 millimeters. That's the optimal size, and a small paracentesis. Here we're seeing an outside view on how my incision is beveled, and I use the same incision, manual incision, in cataract surgery as well. See, I'm going straight, and then I'm going to dip down to create that inner lip in my clear cornea incision. And after using femtosecond laser for cornea incisions in cataract and phakic IOL surgery, we've come back to using manual blades, as this appears to be a more efficient way to create a watertight incision. So we're filling the chamber with ProVisc. This is not an ideal dilatation for this type of surgery, although we've exhausted all topical medications. Ideally, you like the pupil to be a little bit more dilated for easier haptic placement under the iris. So I'm going to use my same keratome to create just a under millimeter paracentesis, and I'm going to use that for my second instrument. And you can see here that our injector tip just fits through the cornea incision, and in my technique I have full control and full visualization how the ICL is going to expand and unfold. Special care here at the trailing part of the lens. It's quite important to draw back here and push again in order to avoid entrapping within your plunger a small piece of the haptic, because that may tear it. And don't ask me how I know this. But in any case, we have now the lens fully within the anterior chamber. I'm going to release the iris. As you can see, it grasps a little bit of iris in its inner haptic. I pulled back my plunger and pushed again to gently insert within the anterior chamber the trailing haptics of this beautiful lens, the ICL lens. And the lens now is within the anterior chamber, and I'm going to use ProVisc. I think this is a very important step over the lens, so it's very important to orient yourself once you're entering in the anterior chamber with the extra viscoelastic. So create a safety pocket between the lens and the cornea, and I'm going to use viscoelastic here. I'm manipulating the first haptic and injecting at the same time in order to place the first haptic under the iris. So we're 1/4 done, and then I'm going to use a Kugelin hook, and it's curved, dull part to place the second. So we're 50% done, and I'm gently manipulating the ICL. Very careful not to push on the lens a lot and have the lens contact the crystalline lens of the patient. And then I'm coming in with my Kugelin hook again to place under the iris haptic number 3, and so on and so forth. This is the Cassini, and we've reported extensively on research with this new topographic device. This is what it looks like. It projects all these LED color dots onto the cornea and then does ray tracing for each individual 3 dots. The beauty of this device, in contrast to placido disc topography, it gives quite accurate measurements in the central cornea and also posterior cornea measurements, so it can give you total cornea measurements. And this is the Cassini image for this particular patient, and how it's able, the data from Cassini topography, to be incorporated in the Truevision or the Ingenuity device. And what we're seeing here is the surgeon's view and superposition of the reticule of the Cassini over the surgeon's view of the lens being placed. And we're going to use the software in the Truevision or Ingenuity device to define the axis, and you can see here where the axis should be. And we're very close with our manual ink marks, just a little bit off, but remember, every 2 degrees of axis shift creates an 8% reduction in the toric power. So it's very important to be torically correct, and you can see that the Cassini and the Ingenuity device confirms that our manual marked axis is not at par. And you can see on the ICL the very faint toric marks, and we're going to line now those ICL marks with our Cassini and TrueView intraoperative axis establishment. We've also used the Varium device by Alcon to center the axis for ICL, and we've posted this on YouTube as well. And we're all done. The ICL is within the desired axis, and you can see there's a little bit of a deviation, probably 2-3 degrees from our manual marking, and we can all appreciate the importance of that. We're going to remove the residual viscoelastic. Very careful, because we will not have protection for the cornea. Last thing we want to do is injure the cornea of a young, healthy patient. We've had great results with the ICL as far as visual rehabilitation. Very quiet anterior chambers. We've never had any problems with the fitting of the lenses, communicating with STAR, the white to white, and calculating the actual lens diameter, along obviously with the lens power and toricity. Our viscoelastic is out. We're confirming correct axis placement will hydrate the wound and use mycol or acetylcholine to attain further meiosis and entrap the phakic intraocular lens. So again, the Cassini raw data superimposed with the Truevision, or what's better known now as Ingenuity system, and how the device recognizes iris and mainly limbal vessel architecture and cyclorotates the actual topographic data to help the surgeon, as we're doing here in another case, lined up the phakic intraocular lens correctly. And you can also see here how our manual markings closer to 5 to 10 degrees here deviate slightly from the actual intraoperative toric axis determination by this very sophisticated system of a 3D direct visualization screen for operative use and the data provided by the Cassini topographer. A great combination, a great addition to the surgeon's armamentarium in pursuit of correct axis placement, which, as you can imagine, is very important. We're seeing here that during irrigation aspiration, we're having a little bit of torque movement of the actual ICL, and we're going to reactivate the Cassini guidance data through the Truevision device and finish our procedure with the optimal toric placement of phakic intraocular lens. So I was mentioning before that our experience with the STAR lens has been only positive. We now go towards an ICL and or consider it at least on every patient that's at 8 diopters of myopia or more, and or if there is significant corneal irregularity, and we're putting together a case series of using it in keratoconich eyes after we have treated them with the Athens protocol cross-linking to normalize the cornea, and we have significant refractive error left behind, and especially anisotropy. But you can see that our manual markings were way off here, close to 20 degrees. And I hope you found this presentation interesting. This is John Kanellopoulos. Really a pleasure to share this information with you.